flexion range of motion is when the knee comes closer to the chest or the chest comes closer to the knee. And I test it as any range of motion in part 2 of my orthopedic evaluation. It's just a baseline. I tend to find that for disorders, people tend to have problems more often in hip flexion, ER, and IR, and less often have problems with extension, abduction, and adduction. But nonetheless, we can test whichever ones I find appropriate for that particular patient's presentation. And unlike other ranges of motion, a lot of people say they feel a pinching in the front of the hip area when they do this range of motion test. And so typically that's not concerning. What's more concerning and what I'm looking for is a limitation in range of motion and a reproduction of the patient's complaint, the patient's symptom during mid-range or of course end range. Range of motion varies from individual to a certain extent. We're looking for about 100 to 120 degrees, but I'm really looking for, can I push that knee really close to the chest without any problems? And of course, this test may be compromised to an extent if there's central adiposity for the patient, but we do the best that we can. So when it looks, when we have the patient in the clinic, it looks like this. The other leg is straight, the knee is coming to the chest, and we're pushing in hip flexion. And then me, standing over the patient, I'll apply some overpressure to that joint as well. And again, we don't have a lot of tissue restriction or muscle restriction that would cause this to be limited and or painful. The hamstrings are on slack because the knee is bent. This is not a passive straight leg raise into hip flexion when we are flexing the hip but the knee is straight, so we're testing the integrity of the sciatic nerve and the hamstring muscles more. This has the knee bent, so we're taking the hamstrings out of the equation and looking more specifically at the joint. We're also taking the sciatic nerve out of the equation. So for joint problems, I'm typically thinking it's mechanical, maybe structural or inflammatory or degenerative, but most problems are mechanical. So if someone presents with limited and or painful hip flexion in supine, I'm thinking it's likely a mechanical problem in the low back, or it's a mechanical joint problem in the hip, or maybe even the SI. And I will add that for most patients, or for nearly all, we can find ranges of motion that are problematic when we do them in this unloaded non-weight bearing position. But on rare occasions, I have patients who have normal hip flexion when it comes to being on their back without weight through the joint. But then when you have them do weight bearing hip flexion, like putting their foot on a chair and then leaning into it so their knee comes to their chest, when there's weight through the hip, that might be problematic, or doing it even like on their stomach in a way. So this is the one that I use almost always, but sometimes I have to be a little bit creative if I think there's a problem and it's not manifested in supine.